Greetings and welcome to this video on Clinical Pharmacology Series where we discuss analgesics, the misdiagnosis. We discuss basically the 20 most common cause leading to preventable acute kidney injury, GA bleeds, and cardiovascular events in case of analgesics use. So, physicians being the most important and the most often person who use analgesics like NSAIDs, paracetamol. This is of much use to physicians. After this watching this video, you will understand what are the basic things that you should consider before giving an analgesia and a final checklist to check and tick before giving an analgesic to a patient. So this video is completely for educational purposes. This is medicine beyond Harrison's. Let's get started. So, firstly, we'll discuss about NSAIDs. It is the most commonly misused drug group. It is the largest source of preventable AKI, GA bleed, cardiovascular events in OPD practice. So, missing occult CKD or subclinical AKI. So, usually a physician could miss subclinical AKI if the creatinine like 1.3, 1.4, or occult CKD like when the creatinine is 2.5. So, what we usually miss is this elevation in creatinine or the CKD status of the patient. Prescribing ibuprofen, diclofenac to elderly diabetics without checking creatinine is a great mishap. Some people even will be taking ACE-ARB inhibitors for their hypertension and will be taking diuretic for their comorbid heart condition or CKD. In these kind of patient, when you prescribe an NSAID, be triple cautious because it will cause a triple whammy AKI, where there will be severe irreversible AKI and can also lead to acute tubular necrosis. So pathophysiology is basically NSAIDs constrict the afferent arteriole. It will crash the GFR completely. So in fact, we give large dose of NSAID with ACE-ARB inhibitor to cause medical nephrectomy in case of severe nephrotic syndrome in elderly. So yeah, corrective action is paracetamol or topical NSAIDs if possible. Always reach creatinine in 48 to 72 hours if the NSAID is started. So missing the cardiovascular risk, second point. So most of the patients who are elderly will be having some or other cardiovascular risk. So giving in diclofenac or ethyloric oxide to such patients is a great mishap. So it will exacerbate the risk of coronary artery disease, stroke, TIA. It will also lead to high BP due to sodium water retention. It will lead to dyslipidemia, and always avoid it in smokers more than 20 years. So because of increased risk of thrombosis and myocardial infarction. So, when to consider in any patient more than 40 with risk factors, corrective action, if there is a cardiovascular risk factor and you want to give an NSAID for naproxen, which is cardiovascular neutral, completely avoid diclofenac or etoposide or other types of NSAIDs. You can give paracetamol up to 3 to 4 grams per day. Avoid toric oxide in all CAD patients. For GA, the next thing. First, we discussed about the gastrointestinal cardiovascular risk and the kidney-related injury and NSAIDs. Now we'll go into the GA bleed risk. So, risk factors. We often have a lot of patients having H. pylori infection or past history of H. pylori infection, and will be on chronic alcohol use, which even 2 drinks per day is a great risk factor. Steroid use and age more than 65. In these kinds of patients, if NSAID is preferred, it will lead to additive effect and will finally lead to catastrophic bleeding and bleeding ulcer. So strategy is add a PA, which provides gastroprotection, and put the top to like it celecoxib if there is a low cardiovascular risk, and switch to topical if possible. And fourth thing is missing early liver disease. In case of alcohol use more than 2 drinks per day, fatty liver, chronic hepatitis, paracetamol, if given freely, like more than 3 grams per day, can lead to cumulative toxicity due to accumulation of NABQI, which is a toxic metabolite, which will lead to abnormal toxicity even in normal doses. So, remember to give paracetamol only up to 2 grams per day in case of liver disease or alcoholics. And if there is fever in a DCLD patient, you try to do liquid sponging to reduce the fever instead of paracetamol. Use judicious use of paracetamol in case of liver disease patients. Watch for hidden paracetamol in many over-the-counter combos. For example, Sinarest, which will come with cetirizine, phentermine, again with paracetamol to be there. Analgesic, where in Tramadol there will be combination with paracetamol. So try to avoid all those things. So bronchospasm and NSAIDs. In case of sensitive asthma, NSAIDs can exacerbate the risk of bronchial asthma, rhinitis, as well as nasal polyposis. It can lead to life-threatening bronchospasm. Always try to use paracetamol or COX-2 selective inhibitors in these kinds of patients. Next, we'll go on to opioids, the common and dangerous pitfalls of opioids and the comorbid conditions. So if you miss a patient with obstructive sleep apnea, there will be more respiratory depression when you prescribe a tramadol or morphine. So OSA cannot be outright been diagnosed previously. Just ask whether they are a snorer. If they ask the attender whether they snore at night. If they are obese and extra compressed more than 40 centimeter. If the person is elderly or having COPD, try to avoid tramadol or morphine. This will cause decreased respiratory drive, further worsen the hypercapnia, and can lead to respiratory arrest. Always remember to start low at low doses in case of tramadol. For tramadol or morphine, avoid nighttime dosing. So, tramadol specific risks are tramadol can cause serotonin syndrome if combined with SSRI, SNRI, or linezolid, can lead to hyperreflexia, clonus agitation, whereas tapentadol or NSAID that do not have the risk of serotonin syndrome. Seizure, in case of seizure patient or a patient with having seizure disorder, now probably coming with headache or body pain or want to give a tramadol, always ensure not to give because even reduced doses of tramadol can reduce the seizure threshold and can lead to a breakthrough seizure, which is much more harmful than the headache or the body pain that they have. It increases the risk of epilepsy, alcohol withdrawal, electrolyte issues. So avoid tramadol completely in these scenarios. So missing renal failure before morphine. In case of morphine usage, always ascertain to the fact that EGFR is more than 45 because morphine has active metabolite called M6G, which is very toxic and can accumulate in CKD in large amounts, can lead to myoclonus, delirium, and respiratory arrest. So in these scenarios, prefer fentanyl, which is safest, or oxycodone, drug adjusted. Neurotoxic agents having some few considerations before giving, like gabapentinoids, should be dose modified for renal dysfunction patients. It can lead to severe sedation, ataxia in CKD. So always start low with 25 to 50 micrograms per day if creatinine is more than 1.3. Amitriptyline, as always said, it is not useful in elderly patients because it can cause orthostatic hypotension, falls, and can lead to subdural bleed in the elderly, can lead to urinary retention, can lead to delirium. So always avoid in elderly patients or cardiac risk patients. In alternative, pigabalin can be used as an alternative. In case of duloxetine, which is an SNRI, it is available in liver dysfunction patients, that is, as it is hepatotoxic. Avoid in alcoholics or ALT more than 2 times the upper limit of normal. Other special populations and the analgesic role in case of cirrhosis, it's an NSAID is an observed contraindication because it can increase the risk of renal syndrome. Use paracetamol less than 2 grams per day in these scenarios or fentanyl. In case of pregnancy in third trimester, do not use NSAID as it can lead to premature ductus closure. Paracetamol is safer in this scenario. In case of alcohol use, there will be cytochrome P2E1 induction. There is a risk of increased paracetamol toxicity even at lower doses. So, limit paracetamol or try to avoid paracetamol in these scenarios. So, last five of the things, and these are the big five interactions that should not be missed. So, NSAID on patients having steroids is a great mishap, can lead to huge GI bleed. uh, NSAID in SSRI patients, there is 2 to 3 times higher risk of GA bleeding. NSAIDs plus ACA plus diuretics, as previously discussed, it can lead to triple whammy AK, irreversible AK with acute tubular necrosis. Yeah, and tramadol and antidepressants should not be combined. It can lead to serotonin syndrome. Methadone with acetylmycin, it can further worsen the QT prolongation. So, final slide of this presentation. Kindly ask yourself these 10 questions before any prescription of analgesic. What is the kidney function? What is the cardiovascular risk? Is there a GA bleed or an ulcer risk? Is patient dehydrated or febrile? Is the patient alcohol dependent? Is the patient on psychiatric medication? Could the patient be pregnant? Is there a neuropathic component? Are they using over-the-counter paracetamol combos? Or if the patient is elderly or with a fall risk? So we have learned a lot of things in this module where we discussed about the various types of analgesics and its use cases. We'll continue this series on analgesics in the upcoming modules. Thank you for watching.